people on the virtual as well. Just the basic housekeeping things. I think everybody here looking around is familiar where all the facilities are and the fire drill. Mobile phones, always useful to remind people to manage their mobile phones. And if you're on virtual, can you turn your cameras off until you speak, just to keep the bandwidth down? Thank you very much. Welcome to the Policy and Scrutiny Committee for Health and Social Care. It's our second formal meeting this year. The committee's job is to raise concerns in the public interest and also to support best practice and initiatives. And in this regard, we're pleased and relieved to note the reports regarding adult social care, especially in consideration of what we've been through this last couple of years. Also, the transfer of specialist cancer treatment to the now University Hospital at Portsmouth, making essential travel for the Isle of Wight patients that much shorter and easier with the option of the Daisy bus, something that wouldn't be available for Southampton. So it's a good news story, and we'd like to have known about it earlier, Alison, but she's not here. You'll note, on the other hand, that we have continued concern over the provision and commissioning of dentistry on the island, a matter that we've been openly critical about. And we are particularly keen to be assured of measures being taken and put into place to avoid the potential cliff edge that handing commissioning over to the ICS will present. We now have sight of the ICP meetings, the minutes and agendas, and welcome the government's recognition of the important contribution that Scrutiny could bring to the new integrated service. We welcome, for example, the coordinated practical steps that are already being taken to address aftercare, particularly, and look forward to seeing issues that strains on public care, on primary care being addressed as well. One of the concerns that Scrutiny has that could be better addressed is that of prevention and the feed into healthcare matters in the first place, especially when they relate to damaging lifestyle choices like diet, smoking, drug use, alcohol abuse, emotional tensions and stresses of modern day life. And we think in order to effectively address these issues, other services need to be involved and aligned, services such as education and policing. They could be more focused, aligned and resourced towards addressing these issues alongside health partners. I don't know what level that would take place at, but it's just an observation. Finally, and she's not here, but when she does come, this is Alison Smith's last appearance at Scrutiny. And we would like to thank her, hopefully, for the constructive way that she's handled concerns that we've brought and the magnanimity and professionalism she's displayed in her post. And we wish her all the best in future, but we'll reserve that for when she arrives. So with that, we'll commence with the meeting. So the first item on the agenda is to agree the minutes of the former meeting. So can I have a proposer and seconder, please? Michael, Councillor Lilly and Councillor Robertson. Thank you.
While signing those, Chairman, we've got apologies from Councillor Andrew Garrett.
Declarations of interest. Any declarations of interest? If you can't think of any and you suddenly realise when you come to the agenda item, just state, be on the safe side. Public question time. Have we had any public questions? Okay. Progress update. We keep table, and that's been circulated to everybody. It's always kept up to date, pretty straightforward. If there's any questions on progress, I think it shows that, you know, we've been quite engaging. Okay. Dentistry on the Isle of Wight. As I said, this is a continuing concern, and we have Alison Cross on virtual from NHS England, and we'd like to first review the commissioning, general dental services and dental need in Hampshire and the Isle of Wight, but particularly on the Isle of Wight. Alison?
Good afternoon, everybody. I hope you can hear me.
Yes.
Yep, good. Okay, so I'll give you a verbal update at the moment, and then I'm sure you have some questions which hopefully I'll be able to answer for you. I do apologise if I have a little cough. I wasn't well last week, so I might have a little cough through it, but I'll try and get through it. Okay, so first of all, I'd like to apologise to the members of the HASC who should have had the review of commissioned dental services in draft format sent to you. Unfortunately, I don't know quite what happened. Our admin team sent out all of the documentation via email, but unfortunately it seemed that a lot of you didn't get it. So currently we're in discussions with our IT department to find out what's happened, whether it was a firewall issue or something else. So I can only apologise that you didn't get those in the time span that we had hoped you to have to review them. I do know that you have the chair has responded, and the comments excuse me, have been sent to our consultant in dental public health, because he undertook the review in draft that was sent to you all, and it is in draft. It's not actually the proposal. It's open for discussion. There was a meeting held within NHS dental team. Unfortunately, I wasn't there because I was on annual leave last week, but the consultant has noted that the way he's written the document, it's not clear completely what the intentions are for our current issues where we're procuring and future-proofing for the island and Hampshire as well. So he has reflected on that, and he'll take some of your information on, well, he'll take your information on board and put some of it into the documentation so that it's more easily read to what we propose to do, and highlight the responsibilities that are the dental team, and those that are what is called a whole system approach. So that would be where we link in with the ICSs and local authorities and the national teams. So he will update the document to make sure that it reflects what the issues are and responsibilities for the dental team and the whole system approach. I just wanted to update you a couple of things on what has happened. I'm sure everybody is aware that it is quite difficult in the dental services at this moment. Thresholds have continued to increase throughout the financial year 21-22 and are currently at 85%. So dentists are doing 85% of their contracted activity. They're still having to follow infection control measures and adhere to a standing operating procedure, and that remains in place even though COVID rules from the government have been released. They haven't been released for dentistry, so we are still following the standing operating procedure, which puts in additional measures for dentists to follow. So the capacity to see a patient as they would have prior to COVID have been reduced, and that's why our numbers have taken a long time to get back up to anywhere near the pre-COVID numbers. But we're all aware that we were given 50 million to dentistry by the government across the whole of the country, and we had an allocated number for Hampshire and the Isle of Wight, across the southeast, I should say. And so we therefore contacted practices who were eligible to see if they had they were able to take on additional activities, because this had to be done outside of their normal contracted levels, so evenings or weekends. Unfortunately, no practices on the Isle of Wight were able to take up this offer. There were a number of practices on Hampshire who were able to do that, but unfortunately not on the Isle of Wight. We have, however, that money had to be spent by the 31st of March 2022, otherwise it goes back to the Treasury. It is still open, so if a practice is able to take on additional, even for the short period that we are left, we would work quickly to mobilise that as quickly as we can, but it is down to the practices. We couldn't ask them to do any more than what they have been doing. It is down to them to make that decision, whether they have the additional capacity to treat patients outside of working their normal contracted hours. You're probably aware that one of the practices on the island has given notice. They gave notice and ceased being an NHS practice on the 31st of March 2022. We have secured some funding to go on from up till the 31st of March 2023 with a local practice. It isn't the full numbers of UDAs that the other practice has given up, but they are still open for any practice to approach us, and if they're able to undertake them, then we will allow them to do those up until the 31st of March. This is to keep a continuation of our normal session levels for activity on the island, because we're aware that we do need to have capacity there for patients to be seen. The only other thing I've got to say is just to update you on the GDC is restarting overseas registration exams. So at the moment they were paused. So a dentist who was qualified overseas was unable to work in England, and don't think it applies to Wales, I won't say that, in England until they had undergone these examinations. So they have now been restarted. They started some in January and are now ramping that up to start getting overseas dentists back into into England. So that will hopefully start to help with some of the activity, whereas dentists haven't been able to work if they were from overseas. So that may help a little bit. I also wanted to talk about, just mention the looked after children. I think you may have mentioned it earlier. There is some work that's been going on for additional sessions across Hampshire and the Isle of Wight for looked after children to be seen. And we have negotiated with Dentaid to do some sessions on the Isle of Wight and also across Hampshire to see the patients who are outside of their national statutory staff. They have to have an examination within, I think it's 12 weeks of coming into care. So some of them are outside of that. So we are trying to deal with that backlog as quickly as we can. And Dentaid are being helpful in providing some of those services for us. So that's my update.
Thank you, Alison. Any questions? So, Joanna Smith, Health Watch.
Thank you, and thank you, Alison, for the update, which was really useful. And it's good to know that there's work being done to address the issues on the island. And I don't think I'd be doing my job if I didn't highlight the extreme issues that people are facing on the island. And again, you know, this is a national issue, but it's compounded tenfold on the island because we've got that water and because people can't just access another dentist in a neighbouring town or city as they can on the mainland. And you've mentioned there about the lack of capacity to deliver dental activity on the island. So how do you think that's going to be addressed within the coming months? Because this is such an immediate issue. And we've got people into the thousands now that have contacted us with problems accessing NHS dental services. So it's not hundreds of people, it's thousands now on our system that have shared their experiences with us, and that are living with pain, embarrassment, going into debt to try and fund the essential care they need. So how are you looking at increasing the capacity for delivery on the island?
It is a problem. I absolutely get that. We're working with the ICS to create a post, which has gone out to advert at the moment, to try and look at how we can get dentists to work on the island. I'm hoping that with the GDC now restarting their overseas registration exams, this will help, because tends to have happened is where people have left because of COVID, or they've gone home and they can't then get back into the country to be able to work. So hopefully some of the dentists on the practices on the island who have lost their performers will now be able to recruit into those positions, because it's not the capacity on the islands for having the units of dental activity. Is being able to provide them. There should be enough activity there at this moment in time. Obviously we are procuring more, but it's actually getting the dentists available to be able to see and treat the patients. So hopefully this post that's been created with the ICSs will help with that, but that is going to take us time. It's not going to be a quick fix, I'm afraid.
Yeah, I mean, this is really concerning, because this is predictable. Certainly, we've been talking about this for a number of years now, and the knock-on effect to other services, I think, is probably tangible, and I'll invite other health partners perhaps to comment on that if they will. Preparation to hand over for the ICS ICP, again, we know that's going to happen in July. What arrangements are being made for that? So, you know, perhaps you can reassure us on that, Alison, but we'll also invite health partners involved in the ICP to see if it's the same from their perspective. And these UDAs, these universal dental, I haven't met anybody that understands what they are. Nobody, you know, the figures quoted in your responses, is that good or is that bad? Indication from the Bembridge dentist who's slung in his hook would indicate that they're bad and particularly not appropriate to the way we work on the islands. So it is very, not having a go at you personally, Alison, because I know you're just there to do your job, but it is really disappointing. NHS England, as the commissioners, have really let us down badly on this. So questions, who's got their hand up? So Michael, then Michelle first. Michelle, would you like to speak first?
Thank you very much, Chair. Alison, thank you for your presentation. It was very useful. There's a lot of emphasis on the new post looking at transformation of dental services. Have you some ideas about how dental services will be transformed? Have they done innovative work in other places? For example, in remote areas where there may not be so many dentists, because I can see that there's a lot of emphasis on this post. So I was just wondering how it will focus on innovation. Thanks.
I don't know an awful lot about the post, I'm afraid, but I do know that the South West have done some work on innovation, and we would look at other areas that are rural to pull in that information into helping this new post to be created and transform the services. They would be working closely with the ICS, but also with us as the dental team. We do want to do the best for you. It's not that we don't. We absolutely do. I really do want to try and make it better on the island. So we'll give this person, when they come into post, all the help that they can do to try and make it better. I've just remembered I didn't update you as to one of the other things that this post will hopefully try and do is in Portsmouth you have the Portsmouth Academy, which trains dental nurses and therapists. They also have dentists who do a third year placement there. What we're going to try and do is look at, with this new post, is how we can get that to become a dedicated training placement for dentists, so it'll be through the whole 3 years that they train. Hopefully that will enable dentists to stay in the area that they train in, because they tend to build up a rapport with and a background knowledge of who they work with and a support network, whereas when they come down and only do like 6 months down here, they go back up to wherever they train, likely to be London. So hopefully that will get them to stay here. If they are cited for 3 years down here, they're more likely to stay, and that will help the position a bit with getting recruitment back into this area as well.
Thank you. Next is Michael, Councillor Lee.
Thank you. Alison, the longer a service declines, the risk gets greater, and there needs to be a reassessment, right, of the needs. So, for instance, example, generations of Isle of Wight children not receiving treatment, right? What is the rollover effect? Because what we're doing is we're accumulating, right? As Joanna said, you know, it's gone from hundreds to thousands. There's a whole lot of people on the island generationally who've got poorer teeth. And that has a huge kind of impact. As a mental health professional for many years, self-esteem is very linked to your teeth, in the sense of they're poor. You can't smile because you don't want to show your poor teeth, and it really affects you. And I'm really concerned that we need to reassess now what is the scale of the problem.
Thank you, Michael. Good point, succinctly made. Alison, would you just like to comment on that, and then we'll invite one of the health partners if somebody would speak.
We are trying to do an overall with the review that the consultant in public dental health has looked at. They are looking at the whole picture, so it will be encapsulating how we work going forwards. The document that was sent out, and I understand obviously that some of you may have not seen it because it went to the chair, but in that document it does turn around and give an overview for what we want to achieve as a whole, not just like the procurement that we're doing at this moment in time. So it's an ongoing issue. So the problem is with dentistry, there's no easy fix. We've got to build this back up, and it has been a bit broken for some time. So we now need to start putting those blocks back in place. There is no easy fix, I'm afraid. We need dentists to work in the area, and we need to get back up to 100%, which hopefully will be coming shortly, so that we can start to build up and get past this backlog that we've got. So I haven't got any answers for you, I'm afraid, but I hear what you're saying.
Thank you. Thank you, Alison. Now we've got Darren Cattell, Chief Executive of the Isle of Wight NHS Trust.
Thank you, Chairman. Alison, really interested in your paper. Thank you very much. I've got a question on page 18 of the pack for this evening. I think it's on page 2 of Richard Wolterton's letter, and it relates to the contract that you're proposing to let for an additional 25 UDAs, notwithstanding the chairman's comment about UDAs. Will that address the need of the shortfall or the gap on the island? Will it actually solve the problem?
But the new contract, did you say? I'm just
Yes.
reading the letter. The new contract that we're going to propose is for 25,000 UDAs. So the practice that has given notice is for just over 11,000 UDAs. So we're putting in over an additional 14,000 UDAs. So that should help. It's very difficult to work when you're working with units of dental activity, the UDA system. You don't know how many patients that's actually going to be able to see and treat. You can only give it as a mean average, because you could have someone who comes in and needs a denture, and that's 12 UDAs, whereas someone who just needs a checkup is 1 UDA. So I can't say for sure that 25,000 is going to be absolutely enough and is going to resolve all the problems, but it is going to considerably help. It's much more than what is currently on the island. So when we procure, you will have 14,000 more than what you've got now.
Thank you, Alison. Well, all I can say is if it's difficult for you, the rest of us don't stand a chance. I've got Simon wants to come in next, and I've got Karen, and then I've got Claire.
Alison, it's really helpful, and following on from Darren's point, I think there is something about how do we really base this on need? And yes, I can understand that one person may need a plethora of different interventions, so that may not be one person for one UDA. But I think with our elderly population, we can probably help you understand that there's more need of the elderly. I guess the other challenge for me is we can commission the activity, but if there's not the supply, it makes no difference. And I think it feels like we're focusing on one bit, but the supply is so important, as you say, with the dental service. I wonder how we can really work together on that, because without any dentists, there's no point in having the 25,000 UDAs.
Yeah, and that's why we want to work with this whole system approach, because it all does entwine together. We can do what we do, commission services, but without the dentist actually there to provide it, and also the support networks, you know, the dental nurses, we're just going to be in the same position. So it is about trying to get us all to work together, and hopefully gets more dentists to work in the area, make it more attractive for them to want to work.
Right, next on the list, I've got Councillor Lucioni.
That is me. I just want to, I know it's all about capacity and we're always going to come back to that, really. But I do want to illustrate, I'm a bit worried about children. So, for example, with Benbridge closing, and I'm pleased to hear about looked after children, of course I am, within 12 weeks. But what about the other children that are falling through the cracks that should get used to having their teeth looked at and and the education around that? So do we have any figures about how many children there are and how many children are actually registered and go to the dentist?
I'm afraid we don't have a figures. Patients aren't registered, so we haven't got a comparison. A patient can go to any dental practice and be seen. Working under the standard operating procedure that they are currently working under, they should start to see patients who are in urgent need, and then they should prioritise down the list for vulnerable, and children are within that vulnerable list. So therefore, they should be seeing those, you know, children should be being up the list and being seen. So it is important to make sure that people know that they need to push the dentist to say my child hasn't been seen and needs to be seen.
So Alison, can I ask what will happen to those children from Benbridge then that won't be able to access it?
They will unfortunately have to go and find an alternative dentist. We haven't got another practice there at this moment in time. We need to procure that practice, so they will need to find one as an alternative in the area.
Next on the list is Councillor Downer.
Thank you, Chairman, and thank you, Alison, for your presentation. Just one point I'd like to make is that with all these trying to find solutions to these problems, which have been going on for a very, very long time, do you acknowledge, and the other people that you're working with, the actual impact that it's having on people's health? Councillor Lilly spoke about mental health, but surely it has an impact on physical health as well. And the other thing I would like to ask is that you spoke about the deterioration in the system, and now it's got to such a crisis point. Why was that not addressed in the very first place? Because it's like shutting the stable door after the whole horse is bolted. Thank you.
Thank you, Rodney.
I'm really sorry, I can't answer your question as to why it got into this state, because I unfortunately didn't work in your area at the time. I know in Hampshire, one of the reasons that Portsmouth has declined with dental access was because of the handback of Coliseum and their contracts. I don't know whether that has had a knock-on effect over to the Isle of Wight. I'm not aware that you've had any other contracts handed back, so I can't answer the question. Otherwise, it could be that it's recruitment. I have heard that it is getting the dentist to stay on the island, because obviously having to travel over, if they don't live on the island, that's an additional cost that they don't want to have to bear. If they can go up and work in London, maybe it's more beneficial to them. So it is making the area more incentivized for someone to want to come and live and work on the island or in Hampshire.
Right, next on the list, I've got Claire Mosdell, then I've got Joanna Smith, and then I've got John Metcalf, Chief Executive.
Thank you ever so much for your report, and it feels a bit like it's lots of words and we haven't moved very further forward than when we last heard from you. I think last time I did say to you that actually to get a dentist to work on the island is maybe to bring some proof to us that you're making it more attractive for them, that, you know, it's all very well to commission a service, but you need to commission it, one, at the right money, and two, to make sure that you're making it so attractive that actually it's the best place to go, because we are at that point that we need someone to come here knowing that the package that they are being provided to come here is better than anywhere else. You know, we all know that there is a huge housing crisis on the island, that trying to buy rented properties is practically impossible. So, you know, our ask would be, if you're going to commission a service, can you try and commission it in a way that makes it irresistible, and so that we can actually get some dentists here, because the knock-on effect is absolutely huge. You know, that's a hugely expensive stretch of water. We need to make sure that you're offering a whole package that says these really good schools in this area, you know, sell it to somebody to come here. That's what we'd really like to see, rather than a massive great document that actually hasn't actually taken us any further to where we need to be, which is actually seeing more dentists working on this island.
Thank you, Claire. Point well made. Joanna.
Thank you. I just wanted to make the point that oral health care is about more than just people seeing a dentist. This is a whole system issue that is affecting primary care, it's affecting secondary care, it's affecting mental health services, as people need these services because of a lack of NHS dentists. The local health watch within Hampshire, Portsmouth, Southampton and the Isle of Wight are coming together to work on dentistry because of the public support with this, and because of the number of people that are coming to us. We feel we have to take this as a priority for this year. So we're planning on replicating some work we've done with GP practices, working with commissioners, providers, with the ICS, and with people from the Isle of Wight Council as well. We're hoping to do the same with dental practices, to work with dental providers, because I feel they hold a lot of the answers to the problems that we face on the island. And the only way we'll address some of these deep-rooted issues is by talking to dentists. They see people on a daily basis. They know what the problems are. They desperately want and need to support vulnerable people and children on the island, but they're not able to do that within the current commissioning model. So I just think if we can get together with dental providers and commissioners, looking at patient experience and putting that at the forefront, then we can put a plan forward, as I say, to address the issues now. We can't wait another year or 2 years while people's mental health and physical health declines. We need to start looking today. And there are a lot of complex issues around the number of dental practices that can take trainees, because we've only got one dental practice on the island that is authorised to take dental trainees. We need more. We need more support for dental hygienists. So there's a lot of work that can be done now, as I say, to support and to give people the service they need. NHS dental services are an essential NHS service. They're not a good to have or an add-on. They are essential for people's well-being. And we need to get this right for island people, and we need to do it now. So hopefully NHS England's improvement will join us in this work to look at how we can support local people.
Thank you, Joan. I think we'll follow a lot of these points up in writing afterwards. So now I've got John Metcalf, Chief Executive. John.
Thank you, Chairman. Alison, thanks very much for the information you've provided to the committee. I suppose the fundamental question for me is that we know we've got a broken market for the provision of dental services. So no matter what we commission, if the market can't respond, we don't get any dentists. What capacity has NHS England to incentivise dental practices to establish themselves on the island? Can you pay more money? Can you provide buildings? Can you provide equipment? What scope have you got to encourage people to set up and provide dentistry to the island's population? Thank you.
So you can't just set up a dental practice, we have to procure for it. So that is what we're doing at this moment in time, and that's why we will have the 25,000 UDA, hopefully one practice on the island, which will be a larger practice. It's not like in 2006, a dental practice could just start and they would be able to get an NHS contract, but that isn't how it works at the moment. We have to go through the procurement process. So it is slightly more difficult in the fact that we haven't got an endless stream of money. We have to work with what we've got, and I think a lot of it is, the disparity between what the UDAs are paid to each provider. They are an independent contractor, so we pay them money and they get their performers into work, and it's about making sure that they incentivize working within our area. It's very difficult to change that UDA value because it's like a double-edged sword. If we up the UDA rate to get more people to want to come to the island, the number of people being able to be seen and treated is going to reduce because we haven't got any more funds to put in for them all to have a larger UDA rate. So it's a bit of a double-edged sword of how we get additional activity in the area and get people to work in the area as well.
John.
Yes, thank you, Chairman. Sorry, Alison, thanks for that answer. If I just might come back on that, I think what I was describing was, I think what you described as well, which is almost a failed procurement process. So you have a procurement process that fails because nobody can respond to it, then you change the process or you change the terms under which you're procuring. I think what I heard you say was that you've got no scope to be able to do that. So you're working within a very tightly confined system that doesn't make any allowance and can't make any allowance for the fact that the island is separate to the mainland.
Yeah.
Interesting.
Alison Smith, Managing Director of CCG.
Hi, Alison, and sorry I was late, colleagues. And I'm sorry if I'm repeating what's already been said, because obviously I came in late. I think we've got a real opportunity. So on the one hand, we've got NHS England who are currently working with the programmes they've got, and the South East region has made a decision to take on some of these services, and we're working with NHS England, Alison and colleagues, to really transfer it over to the ICS. that gives us different opportunities that I think we need to really hold on to. So the work that Joanna was talking about, the suggestion that you've just made, John, I think these are all opportunities for us that we need to hold on to, that as these services transfer over to the ICS, that we raise those through the right bodies and we start to look at things differently. We know the ICS has had the Isle of Wight as one of its priorities. They understand our challenges much better because they're local to us, and I think we need to take those forward. So whilst on the one hand, Alison is given the position that where we are now, there could be a very different position, couldn't there, going forward, that we need to hold on to and really look at what can we do differently. So I just wanted to give that sort of stick of hope that as it comes down to our integrated care systems in the South East region, which is one of the regions that has decided to do that, we do have a different opportunity going forward. And that's not to discredit what's gone before, it's just that as things are moving forward and we look at how we work differently, there could be a different way of doing things.
I think that's very reassuring, Alison, and I think there's been a lot of talk about we need to get together, and but is there from NHS England, is there any meaningful dialogue and transfer of information to the ICP?
So at this
or are
stage,
we facing a cliff edge?
Can I answer that? I would say we're not facing the cliff edge. I would say that, you know, a lot of our professional groups have been in a really difficult position due to funding and also lack of training and lack of support to really take on work that perhaps isn't as lucrative as other work. And that's just saying things as they are. When you look at centralised contracting, it's always a bit of a challenge. And now it's coming down into more local systems. That challenge is still going to be there, but it gives us a route to innovate and to really understand the key issues because we are local. So if we can be patient until the ICBs are stood up, which is in June, July, allow those transfer of services. So I'm not suggesting we do it 1st of July, for example. We do need to take those services on and really get to understand them because we're doing a bit of information gathering from NHS England and start to really look at what does the contract say we've currently got to provide, but what is our local systems? What are they telling us that we need to support? And to the work that Joanna said, talking to those that deliver the services, talking to those that use the services in a really truly integrated way, which is the whole premise of them coming to the local systems into an integrated care board system. Once that is done, once that transition has happened and we've done all of that, then I think that's the time to come out and start really pulling together locally and doing those conversations. But it's got to be done in a stage where we couldn't do it all at once. It's just not feasible.
Thank you. Darren, did you want to come?
Thank you very much. Just picking on something the Chief Executive said about the position really from NHS England. I think we need to understand the need on the island, don't we? I don't think we've got a complete picture. We've got a lot of data with a lot of information, but we don't really understand it, and that's the first thing to do. We can then start working on that capacity plan. But one of the things that we've been quite successful at lately, working together, is to produce a special case. So we are the island, we are a special case. Therefore, how do we convince others that there's a special need for the population of the island? We've been quite successful from a structural deficit perspective. We've been quite successful on a number of other things. So I wonder whether that's an approach we take, and how do we support you, Alison, and others, whilst you're still the Commissioner, and then that transfers later on this summer to others to ensure that the priority for the needs of the population are met.
Thank you, Darren, for that. Right, well, we've got Sherry Gallen of Isle of Wight Advocacy. Sherry, are you there?
I am here, yes, I'm here. Thank you. We mentioned in the November meeting the possibility of the NHS paying for the most urgent cases to see private dentists. So this is something that historically the NHS has done and other areas of their service, you know, particularly around surgery. They've whipped people across to the Spire, for example, when the waiting lists are too long at St Mary's. you know, we're talking about these new things that are coming in that hopefully will be very positive, but we're still talking about 4 or 5 months. And as been mentioned before, it's not just people's mental health. We know that bad dental care can also cause physical problems later as well. So is it possible in some way that the most urgent cases, if you like, are perhaps commissioned, and private dentists are commissioned to deal with those? I know we mentioned it in November. I don't know if it went anywhere from that.
Thank you.
It is not something that we have normally done. I'm not aware of it ever being done in any area that I have worked, but obviously I can take that back and we can feed back. I note that the chair said he was going to do a feedback to us, so if he puts that in there, I think then that can be answered to you formally. Then you'll have a response. Is that okay?
Brilliant.
Thank you, Simon. Did you want to say something?
I'm just going to back Darren's point up about the need. We've got a joint street needs assessment that has need in there, and how we just make sure that you at NHS England moving to the ICS see that. We can share the links through the chair's response.
Thank you. I think this has been a really useful discussion, and thank you especially to the health partners for their contribution. It looks like we've really got a will to grab this and get it sorted. So, Alison, thank you for attending and answering the questions as best as you're able. I think there's stuff that we need to follow up, and we'd be very pleased to be kept abreast of that. Alison Smith, when would you like to see on our work plan that we revisit dentistry? Autumn or winter?
I would suggest we start developing the work plan with colleagues in autumn and bring it back here in winter. I would suggest. Yeah,
that's fine. Thank you. Okay, so we'll now move on from dentistry on to Operation Reset. Sounds very exciting, and Laura will enlighten us on it, no doubt.
I'll certainly try and enlighten you, Chairman. We had an opportunity to run an event on Ireland, a multidisciplinary discharge event, to support our colleagues at the hospital. And Alison and Darren, I'm sure, will chip in at this point in time with any additional information that they want to share with you. As many instructions we received from national bodies it was received at very short notice, and normally we take some time to prepare for this type of event. However, that wasn't gifted to us at the time. So I think the first thing I'd ask for you to recognise is the really hard work of the teams, not only in pulling together the event, but in terms of making it happen, because they turned that around in really quick time to make sure that we were able to support what needed to be done to look at discharge pathways from the hospital. The papers provided to the committee set out a summary of what that review delivered, the outcomes and the actions that are now being implemented. And I don't propose to take you through it in any great detail because you've all had the opportunity to review the papers. What I wanted to focus on was perhaps some of the things that aren't captured necessarily within the slides, and they're probably things you'd expect me to focus on. I wanted to draw to your attention the cooperation between the three organisations, between the local authority, the NHS Trust on the island and our CCG partners. Through that cooperation, we were able to really honestly and openly dig into what was going on, the challenges that our teams were experiencing, and to start looking at some solutions. Some of those solutions were small, some were quite significant and will take us some time to implement, but it really signalled a shift in terms of those working relationships. For the duration of the event, which was initially for 4 days, but obviously has run on as we're implementing the actions, there was no finger pointing, there was no blaming, there was no looking at somebody else who could take the heat or step into the limelight for the challenges that we were seeing. They were collectively owned by all health and social care partners on the island. And that represented quite a significant shift and step forward for our operational colleagues on the front line who are involved in that world on a day-to-day basis. Darren was running around getting printers for people where printers were needed. Alison was running around pulling together multiple slide decks. I appeared like a swan and calmly oversaw the adult social care side of things, although I'm sure that may have a different view from other partners. The key thing was that we were able to identify some really quick wins to deliver better services for local people as they leave hospital. We were able to identify some long-term goals and ambitions to support local people as they leave hospital. But also, equally important, we were able to identify the challenges that our colleagues experience in making that happen. Without putting too fine a point on it, flow is always impacted, and we've seen it in the news this week, by our ability to deliver community care. Working with Alison and Darren's team, we're looking at different opportunities to enable us to do that in different ways. Through the Operation Reset process, though, what we were really able to identify is the challenges we are seeing are coming from an increase in demand, not from a reduction in capacity. People have more complex needs. The support that they need on leaving hospital is higher than it was previously, and we need to reflect that in terms of the support offer that we have available to people. I'm really proud of what every person involved in this project, this reset, achieved. Egos were left at the door, organisational identities were left at the door, and it really was about working for local people to achieve the best possible outcome. Following on from the event, we've done something very similar with our home care providers, and that piece of work took place only 2 weeks ago to identify how we can support people in a different way and release capacity in the community. We've continued to work with our colleagues in our Regaining Independence services across the Adelaide, the Gouldings, the rehabilitation beds commissioned by the CQC and the community unit at the Trust to make sure that we're reducing length of stay for people but maintaining safe onward discharges to the place that they call home. And that's become the key priority for us as a system. With your leave, Chair, I'd invite Alison and Darren to add anything to my brief summary for you.
Thank you. That's very kind. And Laura, thank you. I think it's incredibly important that the committee hears about how we're working together rather than against each other. That may or may not have happened in the past, certainly before my time, I'm sure, and with colleagues' help. I think the key thing that Laura talked about there was the working together and the absolute focus and determination of everybody to do the right thing for the patient and the population. That was really key. Key things to flag, I think, for the committee, in addition to what Laura said, were community care and the issues that we all face with workforce to enable that community care provision to be in place for all of the most vulnerable of our population. That's the critical thing. And I think from a workforce perspective, Chairman, we really do need to come back to that in future discussions. The other thing I think for me coming out, particularly within the Trust, is a rapid, so fast and senior response in any patient pathway makes a massive difference to the ongoing care and the potential aspects for discharge as we move forward in that patient's pathway. So that's something that we're really picking up. And the use of what we're calling the virtual ward approach, so using technology to keep people ideally in their own home, but regularly monitoring that is incredibly important. You know, I said to someone the other day that we've got over 140,000 beds on the island. We don't need any more. We need to make sure that people are kept in the right bed at the right time receiving their care. It's a little bit of a glib statement, but it is actually true, isn't it, that we've got more than enough beds. The last thing really related to increase in the third sector for crisis response for our mental health patients. I think that was a very strong theme that came out and something that we all supported. So this wasn't just an acute hospital focus, it was right the way across our community services into adult social care and that care market that Laura talked about, home care, but also into our mental health services too, and our ambulance services. So we left no stone unturned, but we worked incredibly well. Some of the things we've done, sorted a few printers out, but some of the things we've still got to do, and that workforce thing, I think, and thinking about the market is something that we need to come back to.
But this is a flavour of what's to come. Good, good, great, well done. Right, I've got Alison, did you want to say something? Then I've got Councillor Luciani and Mosdell.
I completely agree with everything that's been said, but I just wanted to give a flavour of how real this was and how we worked together, because I think it's very glib of us to sit and say we worked together. But your Ian Lloyd, was in same-day emergency care, asking really pertinent questions of not only senior clinical staff, but also nursing staff. Now, where would we have been? Where would that have been possible previously? Not only that, we had clinical commissioning groups also asking in our community unit, but also working with Laura and the team going forward in the social care. And I think that just gives you a real sense of the openness and transparency about the working together that has led us to collectively to a point where we have the outcomes that you can see in the paper, but also how we want to do things around here and how we want to carry on doing them. So that is what we've got to cut hold of. It doesn't mean we're going to have all the answers as we go forward, but it does mean we've got a real opportunity to put fresh eyes in different situations to get to some of the really nutty issues. There was something like, and I can't remember the exact number, forgive me if it's in the pack and I'm trying to recall, 230 actions that were closed in those 4 days just by the joint working. There's clearly a series of actions that we need to follow through, but just by working together, we were able to demonstrate what we could achieve when we pulled together. When we stop and we focus, and when we do it openly and transparently as a team. It was a phenomenal piece of work and a great piece to take forward, and that learning about how we want to do things.
And Darren, you wanted to just say something?
Just forgot to say to the committee, actually, we managed to promote the work that we were doing with the region. So we got a regional recognition of the work that we were doing. And the regional director actually joined our launch event on the day. And she was so impressed that I got invited to go and talk at the national stage to promote the work that we were doing on the island, and it was incredibly well received. So I think we're really making some, big strides off the island as well as on the island, which is really good to hear.
What a good news story. Thank you. Councillor Luciani, Councillor Mosdell, then Councillor Lilly.
It's actually pecuniary interest because obviously I work with the PA Notice Board, so I have actually helped with this, taking people out of hospital. But I just wanted to illustrate, actually, as much as you've done good work, it's actually the people on the ground that have really helped take up that slack as well. So I just want to acknowledge them, not myself, but everybody else. Thank you.
Thank you. Councillor Mosdell.
Thank you, and it's always really good to hear that everybody's working together. Because of COVID, we can't all have a group hug anymore, can we? But it's good to hear you're working together. Some of my questions would be then, it's all very well to say that we're working together and we're sending people home, but the data we need to see is how long are people remaining within that home, and are we sending to people to the right place? If someone's gone home and they only last at home for a week, then maybe they shouldn't have gone home. So it would be really interesting. We can come back and see some of that data of how long people are staying within their own home, because we can have this urgency to discharge them from the hospital, but we need to have it proved, don't we, as a community, that it's being done safely and correctly, but also for a more long-term effect. Some of my questions would be as well that it'd be really interesting to see how we're working across the system to improve things like the bariatric care, and how quickly you're getting that sort of things into operation, and that level of understanding that some of those complex needs of people being in the hospital is actually because they can't get the equipment, very specialised equipment, back at home to give them proper safe care. So yes, I think you've done absolutely fantastically, but I think there is that next stage of information that needs to come back to this committee, because this is the initial, but I know we've been doing it for a long time with Friday detox meetings, and this is fantastic, but it'd be really interesting to hear that, is it just getting people out, or are we actually keeping people in the right places for a period of time safely and getting better as well?
Great questions. And Alison, you.
Yeah, and this is going to be a challenge for us as a community, because the reality is most people want to go home to their own place. They don't want to make decisions about leaving their home, their neighbourhoods, even if it's not what we would choose. They still don't want to make that decision while they're ill in bed or recovering in bed. So there is something about our tolerance for the risk about that we are going to have to address. And I say that very kindly. And I say that also, you know, my mum, God love her, would never want to leave her house and would not have to make a decision about going into care or even have a carer in her house when she is not there. So there is some, I think there's some tolerance that we're going to have to give about we might have to try something, suck it and see, and then come back. And the other point to mention is we did an awful lot of work during that week about releasing equipment because we recognised straight away that was going to be a challenge. And not to take anyone's thunder, Laura, but that was an immediate, we've got to get more equipment, we've got to release it, we've got to have it available, what hoops do we have to go through, what can we minimise? So some of those things you've mentioned, I think, are really going to test us as we go forward about what our tolerance level is.
Look.
As part of this, is there looking at talking as a system that there is only so much equipment that's already been purchased, and is it addressing the type of changing needs of the people at the hospital, such as bariatric beds, that as a system you will fund and help make sure that that's available to the people such as Laura who needs it?
Good. Laura.
The Isle of Wight Council runs and operates the community equipment service on a monthly basis. I review the data in terms of their performance, and I can tell you that 98% of discharges equipment is provided within 24 hours. So we're not seeing any challenge there. Part of that team's remit is also to regularly review our catalogue of equipment, and that's also refreshed and updated every quarter with occupational therapy input. So we know that the equipment we're buying is the right equipment to meet the needs that we're seeing. We had a bit of a wobble when a big boat got stuck in a canal and all of our equipment ended up floating around on the ocean, which led to some unanticipated delay. Similarly, now we experience challenge in the rise in the price of steel or the rise in the price of fuel, but these are all changes which the team are really adept at dealing with. There will always be something that impacts upon our ability to source the equipment we need. What we have is a big store that contains an awful lot of equipment, and there's quite a bit of money sat there just waiting to be used, and the team are also responsible for collecting that equipment when it's no longer required, decontaminating that equipment and reusing it. So we're getting maximum bang for our buck in terms of that piece of work. Turning to the how many people are still at home afterwards, I think it's a really important question, but what we need to be mindful of is that when a person leaves hospital, only 10% of that cohort of people receive support from us moving forward. So we wouldn't know for that 90% save for whether they represent, and that data is quite difficult to keep hold of. For the people supported by our reablement services, every quarter we report through ASCOF the number of people who are still at home 91 days after they've been discharged from hospital. Our performance there isn't as good as it should be, and that's for two reasons. Firstly, there is no ability to filter that number. So if I was discharged from hospital on the 1st of January and hit by a bus on the 1st of February, I'd be a failure for the local authority in terms of that data count. My presenting issue is nowhere near the same as what it was to begin with, but the ability to cleanse that data isn't there for us. So it can be a bit of a red herring. In addition to that, our population are older, our population are frailer, and the people who go to hospital tend to then experience something unrelated perhaps that causes them to be in need of health services again, and that would reflect in that data. So we're mindful of it, we're looking at it, we'll continue to monitor it, but we're confident that we've got the mechanisms in place to collate that information now moving forward.
Thank you, Laura. Councillor Lilly.
I mean, thank you for this, and we should praise, because there is a good news story here, and thank you for the hard work with it. It's quite interesting. In the past, if you look at successful co-production, the Safe Haven was created by a conversation between service users and psychiatric nurses and the psychiatric team, and that came out of it some years ago. And it's quite interesting that you're now looking to expand that into rides. So we know co-production works. The key is maintaining it And that's what we, I suppose, as a committee, that we need to have that dialogue to do that. But I just want to raise some of the lessons learned. I think that the key still of, you know, the former Shackleton ward and dementia, and getting people back off the island. And I do wish to praise the dementia strategy, because that was a real piece of work between the third sector, families, things, as well as the services. And I think you're in the right direction, but we've got to hear at a future meeting that not good story of the past of Shackleton dementia we get over. It's still haunting us, and we need to get back on that. I think, again, the carer strategy, and, you know, within that, you know, it says here the gap in provision around community respite for service users and things, particularly through COVID. We have carers on the island that are on there by their nails, you know, and they're wearing thin. And there's a very thin balance between being a carer and a cared for. A lot of elderly people with ailments looking after elderly people with ailments that are just worse than theirs, right? And if we look at our demographic, so again, reporting back. And the other area, yes, there's a better relationship with the third sector, but the third sector also needs resources, and it needs to, you know, maintain. A recent grant that came through public health that was going to peer support, we need to do more of that. That was just a drop in the ocean with 54,000. Thank you very much, Simon, for finding it. But we need to get more resources at grassroots peer support. And that's how we got through COVID. If it wasn't for those 33 hubs working on the ground with the Isle of Wight Council, real partnership, and working with parish and town councils and yourselves, we wouldn't have got through COVID the way that we had. And so I just want us to praise, but we've got to make sure we can maintain it, and we don't go back to some of the things which were just not good. Mm-hmm.
Thank you, Michael. It looks like your points have been noted. So, did you want to say anything?
If I can, Chairman, going back to Councillor Mosdale's points, working together is great, isn't it? But we've got to still do things, and we've got to get things done. And I think that's the next phase. So, Councillor Lee, you talk about sustaining things that we've done, improving on things that we've done. We need to continue with that. One of the things that we're very anxious about within health is that if we have a number of patients that are medically optimised, so ready for care in another care setting rather than the acute hospital, not only are they taking a bed that someone else almost certainly needs, given the demand on our emergency department, it's an expensive use of resource. Now, if it's appropriate, it's more than fine. But if it's not, then that resource could be better spent somewhere else. And all the community work that we've been talking about, and we need to continue to talk about, will be a much better use of that resource, wouldn't it, for everybody? So that's the holy grail, really, isn't it? That's the bit that we've got to tackle. I think I talked to someone about constraints the other day and boundaries, and Laura, you supported me on it, if you remember. Some are real, some are organisational, some are imaginary. So if we can dispense with the imaginary constraints, we're going to do more and do better for our population. But thank you.
Thank you, Darren. And we'll move on now to item number 7, which is you again, Darren. Health and care plan. Or Michelle, is it? Michelle, sorry.
Yep, I think I'm going to do it, Chair, if that's all right, but I will be in the spirit of today with my colleagues around the table. You've got a pack of slides, which I hope you've had a chance to look through. I'm not planning to go through all the slides, but maybe just direct you to a few highlights. The health and care plan, the first thing to say is huge thanks to my colleagues around the table, because we've been really working on this together. And although she can't be here tonight, Michelle Young, who works at the Trust, has been absolutely amazing in coordinating this. So I would just like to say thank you to her and have that noted, because she's really been leading this and is really passionate about it. So she's been a great inspiration to all of us. So if I refer you to slide 3, which is why do we need a new plan? Because, you know, people are always saying you get a new plan, but actually we've got lots happening at the moment, particularly which we're going to talk about later, which is the health and care bill, and the fact that we are changing and we're going to be an integrated care partnership, and we're going to be a local place with a lot of localism very much promoted, and that will all change the way that we do things, rightly so. But also our community are changing. We've just gone through COVID, which has already been mentioned tonight, and actually what is happening to the needs, and so that we really do need to look at our islanders and make sure that we're not looking at something that was fit for purpose 2 or 3 years ago, but actually we've had significant change in the last 2 or 3 years. And today people have already mentioned deprivation and prevention, and I think when you look later in the slide pack, that's something that we're really going to focus on. So firstly, we always need to make sure that we're current and make sure that we are addressing anything that's changed. If I just look at slide 4, which is how we are going to work together, and we're going to talk about it a little bit later as well, but we've got an integrated care system, which is Hampshire and the Isle of Wight. But what's really important is our integrated care place, and that's where we're really going to make a difference. Looking at our Isle of Wight Health and Care Partnership, looking at our Health and Wellbeing Board, looking really at our population needs. We talked about dentistry earlier, saying that we really understand what's happening on the island. Nobody else will. Nobody in Winchester will understand what's going on, which is why place-based commissioning, place-based delivery of services is so important. And then we'll drill down to neighbourhood, because actually what's happening in Bembridge may not be the same as what's happening in Newport. So we also need to make sure that we're aligned with what's happening at neighbourhood, with our wards and our neighbourhood population. We also should be quite proud of what we've already achieved. So it's not like we've not done anything in the last couple of years. There's been an enormous amount of achievement, particularly the Trust now becoming good in its CQC rating, which is a great achievement, done really quickly. We've also noted reduced reliance on expensive agency staff, which is really important for making that pound stretch further. And we've already talked about how resources can be spent better. More people have accessed social care support. Our stroke and cancer services have improved. We've done an amazing amount with mental health and learning disability, more to do, but there's also been a great improvement in the last couple of years. The ambulance services are using technology, and hospital services became more resilient because of our partnerships with mainland partners, and that's important for the island as well. So when we're looking at a health and care plan, we always need to look at data, and data is really important, and that's something that I'm really, I'm quite a data geek, and I really love data. We really need to look at the COVID impact. You know, it's been huge. The chair has already mentioned tonight about prevention. We know that health has deteriorated in the last couple of years. We know that COVID has produced its whole new raft of problems. So people's lifestyle has changed. People lost work, their health would have deteriorated. We've got a huge tsunami of mental health issues, particularly in our children. They have a huge amount of anxiety, which we're just about seeing. A lot of people have COVID anxiety. I'm one of those people. I'm very anxious about COVID. I haven't had it yet. I'm really nervous. What's happening? What's going to happen in the future? And so all of this needs to go into our current health and care plan. But it wouldn't be right and proper tonight without talking about our aged population. That's what makes the island really unique. We have 1 in 4 people on the island currently are aged over 65, and 1 in 6 people on the Isle of Wight are socially isolated. They moved with a partner, spouse, and one of them died, and they've come down without social networks which they left on the mainland, and that makes it hugely important for preparing services to meet those needs. We've also got an increasing population. We've got an increasing population, but particularly in the very elderly, so particularly in those over 80, and that makes a huge difference to services. So all of that needs to go into how we're thinking about our health and care plan. So older people, I just very briefly mention, because, you know, being a doctor, I have to mention long-term conditions. We really have a really huge amount of elderly people with long-term conditions, and that makes a huge difference to planning our services. And we really need to factor that into any areas of focus. So my favourite slide is slide 11, because it's a doing slide. And we do have a tendency to make plans, talk about our plans, review our plans, but do we actually deliver on our plans? But that's where the integrated care partnership will come into it, from the closer working, and also we're going to be pushed into making extremely comprehensive plans, which as a place we will have to deliver on. If we're going to have that being authentic and really delivering in the future, in the next year, we will have to deliver on some of our plans that we identify in our health and care plan. And my favourite, of course, would be frailty. We have lots of pockets of extremely good work of frailty. We have high intensity users. We have a 2-hour service which goes out to frail people if they're in acute need. But actually, we need to pull that together. And we wouldn't be able to mention frailty without mentioning dementia. I've always been a dementia advocate, and actually it's hugely important for carers. But we need to pull that together, look at areas which we're missing, pull together the really good work, share that with colleagues that I was, you know, already doing it, that they may not be aware of. And then we need to plan and to deliver on that, probably within the next 6 to 9 months. And is another, you know, another shout out from Michelle Young. She's really keen on doing this. We're really keen on doing it together with our partners. We've got a community day where we're going to bring this all together, look at our gaps, and get delivering it, get something tangible that we can show in the next 6 to 9 months. So clear pathways, clear ideas, community support for people with chronic conditions. But I'm also, you know, I would have to mention, I work in Ryde. My father lives in Ryde. We need to really help people, support them making healthier lifestyle choices. And that's a difficult one. And we really need to engage with people and ask them what would make a difference. I've got an idea, but my idea will be completely different to somebody who's living in Ryde with potentially difficult housing, potentially difficult social circumstances. How do we make them make those decisions that will make their health healthier? So give up smoking, etc., etc. And that will be a co-production piece of work which we're already starting to do, which I can talk about at another time, because I could talk about that now, but I mustn't get too carried away. We need to scale up services as well, and we can only do that with working with partners. We need to tackle the social care challenges that we have, and we are mindful of that, because obviously sitting around the table when we're looking at this health and care plan are our social care colleagues. We need to provide more care closer to home, but we also need to understand that people have to travel for some of their care, and how do we make that easier, and how do we make that better for our older population? And that's working together, and we can do that. I'm absolutely sure of it. You'll be obviously expecting us to engage with our community, and we've just been doing that. We want to know what they're feeling, where they feel that there's problems. And if you look at slide 13, that's all the areas where we've engaged with. The key things are access. It's you know, obviously access to GP services and face-to-face GP appointments. We've done a huge amount of work on that, but I won't get into that. Dental services, we've already talked about tonight. A better access with coordination with our mainland services. A lot of people, in order to get that bespoke treatment, need to travel, but we need to make sure that they're not given appointments at 9 o'clock in the morning. We need to make sure that it's coordinated and joined up. The chair mentioned earlier about the Daisy bus and some of the services, our cancer services, moving to Portsmouth. Well, how do we make that work on the island as well? Because it's not just about travelling over on the mainland, it's about getting to the boat, getting over with support. If you're 85 and it may be a big thing to actually travel over to Portsmouth, I would be nervous about travelling over, making sure I wasn't going to miss a boat. So we need to make sure that when we're looking at our services, it's joined up for our older population. We've already mentioned that we know we have an aged population. We need to really make sure that working together, particularly in this health and care partnership, it's a great opportunity to do this. We absolutely need to look at support for children and young people's mental health services. There's lots of things that we need to look at, but we need to focus on one or two, really show that, have a plan. Some of these things are going to take longer, but we do need to deliver on some of them. We absolutely need to do that. So we've obviously involved staff and public. We've engaged with our staff who absolutely have ideas as well about this. So we obviously will need a timeline. We're going to launch our health and care plan. I've already mentioned briefly our day when we're going to look at how we possibly look at community strategy and a frailty pathway. But actually, I think it's a really exciting time, and I think we should be really positive about this. Thank you.
Michelle, thank you very much for that most inspiring delivery. Thank you. I think we'll move straight. Michael, did you want to come ask questions on this, or should we move straight to the next item, which is sort of related?
I wanted to make the point. I'm totally with you, Michelle, in everything you do. I do think that about the voice and the voice of the people who use the services, and I think the link from the work to Health Watch is really important. But if you look at just one example, you say of children's mental health, it was actually the work of Isle of Wight Youth Trust, their service users, their task force, which was the reason that this island got the first money for setting up the consortium with Bernardo's Isle of Wight Youth Trust and CAMS, i.e. the NHS, to get that money to get a bespoke service in all the schools within that. It was actually those young people's voice, and that was actually said why we got the top marks. The NHS England, the funders said, we gave it to you because of that voice, and we need to really do that right through all our services, give much more focus to them, because they will help with the solution. And I think of that. The other particular point is about working with town and parish councils. COVID has really shown that. And if you look at certain areas like in West Wight, Ventnor, and in Ryde, you've now got very active town and parish councils that are putting money into services. So recently, with some funding that came from public health, there was match funding that came from Ryde Town Council through its community fund and side. And we need to be really looking at that. And this area of recruitment, it's right across, but we need it at all different levels. If you look at all the mental health services, they're struggling to recruit just, counsellors at different levels, tier 1 and 2, right through to clinical psychologists. We've got to work with universities, which is what you've done in areas, and actually building up our own Indigenous people to go into those professions. There's some good examples of how they've done it in BME communities where there were no people, and they've had to go into schools and start working in schools to get that next generation of professionals. And we really need to do that because it's right across within that. And my last point about travel is, when the ferries finish in Ryde, 2020 is the last one you can get back from Portsmouth. How can people visit people in hospital? How can, of that? And also, you've now got professionals that come over here that live in Portsmouth and Southsea are actually not giving up jobs here, right? Because they can't do shift work, and it works the other way. And we do need to be really bashing the providers, right? To say, you have got to go back. Before COVID, we never had this. Before COVID, we had services that finished, the last one was at 11 o'clock. Why are we got an operator that closes at 2020? It's just not good enough.
Michael, thank you very much for those really well-made points. And actually, at last full council, there was a request from the cabinet member, could we take the transport issues on and off the island to health scrutiny, because we wondered whether there was more support we might be able to get, or more input from health partners, and I think that's well received. So thank you for that. Claire.
Thank you. Yeah, brilliant. Really well presented as well, Michelle. My question is to all of you, really, that we know that social care is in crisis. We know that the government has said that they're going to increase national insurance, and that's going to go to health and social care, but actually it's going to go to the NHS for 3 years, and it's not going to come to local authorities. I've sat in this position before and known that we all have very open and healthy conversation about finance and things like that, but we all understand as well how budgets are produced and how you can't just get the NHS to just give the local authority a pot of money to help out. We are acutely aware that Laura's job is practically impossible, because actually, if you're sat in Laura's position, anybody working within care homes and stuff like that have all got to be vaccinated, or they've lost staff within there, whereas that isn't happening. And I see there, we're looking at joint workforces and stuff like that, and that's a fantastic line to look at. But actually, the reality of that and transporting money and transporting the different levels that's been hit on social care to actually what's happening within the NHS. I just would like some assurance that you're having those open and honest conversations, because it is easier to recruit and get people to work on the bank at the hospital when you can pay a lot more than it is for Laura to be able to encourage care homes and stuff like that and do, the annual fee reviews and that. It is meant to be this one look at workforce, but actually the complexities of having that workforce, I would love to have seen, more money going into social care, not just to the NHS. I'd just like some reassurance from you, but I know it's a very complex question.
Thank you, Darren.
Thank you, Councillor. Yes, it is a complex question, you're right. I think there are some fundamental things. Maya touched on workforce earlier on. I think that's the key thing for us to ensure we've got sustainable services. So I think that's something we definitely need to come back to. And some sort of parity over time has got to be our aim. Now, that is not affordable right now, is it, Laura? But we need to work together collectively to how to crack that particular thing. In terms of things that Councillor Lee was talking about in terms of growing our own, we are already in schools to both explain, educate, provide information, what we're calling a grow your own workforce kind of approach. And Lois, quite rightly, has just reminded me, we've got a partnership now with Portsmouth University to talk about how we would access graduate placements here on the island too. So there are some good things happening. Yes, we need to do more, and we need to do it quickly. And I'm sure you've got another question.
Yes, just that, and that absolute assurance that, you know, if you were 23, had passed all your care certificates and really proud to work in care, but actually you went to rent a property on the island at the moment, which is practically impossible to do, would you go and stay working within the local care home that you work, that you're earning just above minimum wage, or would you go and do a few shifts up at the bank at the hospital, where you're going to be able to earn a lot more than you would be doing at the care home? And I think that's the real reality of the situation at the moment. So I know Laura might say it's a bit different, but I just feel that it's such a tricky and complex question. We need some assurance that you know that you can't transport money, but you will be doing something to work together within that system.
Oh, sorry. I think we've got some early plans, and the conversations that we've been having recently would suggest that, well, let me put it a slightly different way. So at the moment, we've got a number of patients that are what are called medically optimised. So they're ready for care in other care settings. They're not receiving acute care. They're receiving some form of community or actually, in some cases, social care. So we're already paying for social care within an NHS budget. So there are opportunities for us to talk about how we might do that differently as we go forward.
Thank you. Yeah, that's great, Laura.
I think that's an opportunity, but there's other things that are at play as part of our system. We've got a really strong workforce group now looking at the picture for recruitment and retention right across the island. We've got recruitment campaigns lined up which target support for the independent sector in their recruitment. Our offer doesn't always have to be about the money, and in actual fact, by investing in our staff in different ways, we can show them their worth. Our care workers on the island and our health care workers on the island have been exceptional, not just over the last 2 years, but always. They deliver time and time again. They support our most vulnerable residents in the most harrowing of circumstances, and it's really important that we recognise that. In an ideal world, I'd absolutely want to see a living care wage for the island, something that isn't the living wage, that's comparable with the band 3, the band 2 posts in the trust. It's just not possible because of the lack of central government funding at the moment. We're working that through in different ways and looking at shared staff, a generic health and care worker who can sit across both parts of our system. We're looking at the enhancements we're paying to our care homes to support them in different ways through reducing the costs they incur for advertising vacancies, supporting them to retain costs through absorbing those centrally. So whilst it doesn't add up to the pay packet amount that I don't think anyone in this room wouldn't want to see, what it does do is show that we value that really key and professional workforce in a different way. I meet with Darren on a really regular basis. We're always talking about the money. Whatever conversation we have, it comes back to being the money. And the point you made about that social care levy, that additional 1.75% in everyone's pay packet that isn't coming to social care is a box that I will stand on for the next 3 years, I'm sure, regardless of what role I have in the future. It is what it is, and whilst it's really disappointing for local authority in terms of investment in social care, the relationships we have, the processes we're building, the trust that is developing here on the island, possibly stands us in better stead than colleagues in other parts of the country.
Thank you. Chris.
Thank you. In many ways, it's a bit of semantics, really, but I'm comparing your page 4 with page 11. It's the triangle and the areas of focus. And I'm looking there and I'm looking at place and I see Health and Wellbeing Board. Great, fine. Then I look at the list and I think a lot of those are about promoting well-being. And I think that's what Michael's also trying to say. And that action, I think, will take place more so at the primary care network level. And I'm just wondering whether it just it's semantics, but give an indication in the framework that this will involve the voluntary sector, it will involve the town councils and the parish councils, so that when this comes to fruition, people will see that they've got a role to play in the future in developing for their local people. And it brings everything together, I think, at that point. The word well-being being separated from the word health and well-being in that sense.
Brilliant observation, Chris. Now we've got Michael. Can you turn your?
Oh, sorry.
And we've got dear Rodney now.
Just an observation on about the access to GP services and GP face-to-face appointments. Now, during COVID, of course, there was hardly any, was there? Have you got any statistics about if there's more face-to-face ones now? Because I think that's rather important, because it will give people confidence to be able to see their GP. It's not like years ago when you could just go into the waiting room and sit and wait for the doctor to call you in now, is it? I can remember that. But is there any statistics, please? Because I think it's rather important. Thank you.
So just Alison will give you the statistics because she's very good at that. Just to point out still that we are still having high levels of COVID on the island. So we are triaging people first, or telephoning them, making sure that they are not got symptoms of COVID before we invite them down to the surgery. When we are dealing with vulnerable people, maybe somebody on chemotherapy, babies, elderly people, when they're in our waiting rooms, we need to ensure that they are safe, as safe as they can be. And we also need to make sure our staff are safe. So we are still doing some telephone triage, just checking that people don't have COVID symptoms before we see them face to face. But I will hand over to Alison now for the stats.
It's a really good question. I just want to take us back before I answer that question directly. Before COVID, it's hard to remember, isn't it? Because it's been with us for such a long time. There was always virtual consultations available from primary care. There was always a telephone, there was the video, but also eConsult had already been launched. And during COVID, that was really put into the forefront of how people communicated with their practice. That was partly because there was a national decision that we needed to offer more modalities for people to liaise with GP services than just the face-to-face. So I want us to remember that. But having said all of that, I looked at the stats this morning just by chance because they came into me this morning. And last week, for example, in comparison to pre-COVID, we had a 17% increase in the number of people that are seeing doctors and their teams on the island. So I can say with all assurance, we are absolutely making more available than we were before. It doesn't mean that that is still going to remain the only way. It means there's always going to be a mixed modality. For some people, using a computer, using social media, directing themselves through telephone and video is preferable than going face-to-face. For others, face-to-face is the only way. And the reason we have a mixed modality is for those people who can only do face-to-face, that availability will be there for them, and we've got more of it. For those who prefer to use different methods, then that's available to them. The reality is that primary care and their teams, they have to be open to all modalities of access, not just face-to-face. So I hope that answers your question, but it's a bit of a broader answer.
Thank you for that.
No, thank you very much. I can appreciate the rate of infection of the COVID at the moment, but yeah, I managed to use my NHS app and order some repeat prescription. I mean, a computer philistine, but there you go. Thank you.
Thank you, Rodney. Darren.
Thank you. Chairman, thank you. Something you just said there, Councillor Downer, the community infection rate, the prevalence, if you like, is obviously growing. And I think I'm just going to start, but I suspect others, particularly Simon, will want to come in. I'm just going to take this opportunity to say it's growing, and we are seeing a definite increase in the number of patients that are coming into our facility, both with and are testing positive for COVID as they come in. That's doubled over the last week. So we are seeing a significant increase. Now, we know through all sorts of reasons about relaxation of measures, but I wanted just to use this forum really as a way to remind people about safety and prevention and precaution as opposed to treatment after catching the virus. Thank you.
Darren, while you're on, do you want to talk about the changes in the cancer service that I mentioned earlier? It's a good news story, but I did make the comment that we'd have liked to have known about it earlier.
So perhaps I'll just explain what's happening with the service, and then Alison can pick up the difficult one. That's because you came late. Sorry, that was a bit cheeky. So the services are moving from Southampton to Portsmouth. And what we're really pleased about is that that centre is able to provide the real specialist care for cancer patients. So we're really pleased about that service. Now, clearly, some parts of the island are more accessible to Southampton travel and treatment, and some are more accessible from Ryde over to Portsmouth, etc. So we know it will present more problems for some, and it will solve more problems for others. What we've looked at is where the best possible centre for care is for the population of the island. So if we need to have other debates, and I'm sure we will, about travel and arrangements and time and funding of that, then let's do that another time. But the really important thing is that our patients are getting the right possible care from the right place.
Thank you for that. Did you want to make a comment on the delayed notice?
I will, but I think actually Darren has alluded to it. Whenever you're doing a change and looking for the best quality, it takes a bit of a negotiation. And whilst, particularly when you're looking at the high quality services that we need. So whilst I apologise for the delay in notice, I would also say you've got the best result that you could possibly want for the people of the island.
It's such a good news story. It's you know, we could have possibly made more of it with a bit more notice.
And hands up, John. You know, it's a mistake to get focused on the job you're doing.
That's good. That's good. Right. So we'll move now to update on the integrated care partnership and other key elements of the health and care bill. We had Michelle down for that, and you were dabbling in between the two, so if you'd like to carry on.
Fantastic, I will indeed. So the Health and Care Board, presently we have an integrated care partnership on the island, and we've had that for several years, and it's allowed us to form much better working together. You've heard tonight of how we work together. Well, in order to work together, you have to form relationships. You have to learn how people function and how they work. And we've been doing that for at least 3 or 4 years now. And actually, our integrated care partnership on the island is flagged up to other parts of Hampshire and the Isle of Wight as somewhere where it's working really well. I think it's fair to say we've always been a little shy of taking it that next step. What is that next step? What will that be? But actually, the changes that we're going to see in the NHS is actually going to push us into making that next step, formalising how we work together. In other areas, for example, North East Hampshire, geography isn't so well defined. And so they're actually starting in a place where they're trying to look at their geography first. They're looking at which part they will form together. We on the island have a perfect geography for working together, absolutely perfect. And so starting in July, there will be an integrated care system, and that will be across Hampshire and the Isle of Wight, including Portsmouth. But in all of the paperwork, in all of the communications we hear, we know that place is absolutely vital, because that's where we absolutely understand the needs of our local population. What works well in Winchester may not work well on the Isle of Wight, but some services do work well over a whole geography. So something like maybe immunisations or something like that, that could be commissioned once across our geography, Hampshire and the Isle of Wight. But how we deliver it locally will be up for us to decide. So I see the health and care plan and partnership and the bill that's presently going through the Lords, I understand, as a huge opportunity for the island. It's where we will work closer together. And then I do believe it was on the 9th of February, there was a white paper released. And this actually laid out in much greater detail, particularly how the CCG, or Integrated Care Partnership, the NHS part of the Integrated Care Partnership, how it will work closer with our local authority. And again, on the island, we've got a great opportunity because we've got one local authority. And the government's going to lay out how we can do this. So it's looking at finance, it's looking at technology, it's looking at how we engage with our citizens. And I've done a summary of that white paper. Actually, it's not really a summary, it's several pages. But if I look, and just do some highlights for you, the government's very much looking at local arrangements and local care partnerships, local boards taking ownership for their needs of their population, working together and actually agreeing at a place level which priorities will be done first, which priorities are important. And so the government's saying in this white paper that actually there will be shared outcomes. They will consult stakeholders and set out a framework with a precise number of national priorities and approach for developing additional local shared outcomes by spring 2023. They're also talking about aligning other priorities and how we can do that together. Ensure implementation of shared outcomes will begin from April 2023. And why I'm putting emphasis on that, it's a year away. They're looking at reviewing Section 75 of the 2006 Act, which underpins pooled budgets, to simplify and update the regulations. We're going to be looking at, the government will work with partners to develop guidance for local authorities and the NHS to support going further and faster on financial alignment and pooling. There will be published guidance on the scope of pooled budgets in spring 2023. They're going to work with the CQC and other organisations to ensure inspection and regulation regime supports this and promotes the new shared outcomes and accountability arrangements. They're going to develop a national leadership programme addressing the skills required to deliver this. They're talking about each health and care partnership, so our local Isle of Wight one, having one person leading that to be accountable, an independent person, so not a CCG person, not a local authority person, but somebody that's independent, but obviously has the capabilities to deliver this programme. They're talking a lot about digital and about how our citizens will access their health records, but also their social care records. Because for a lot of people, this is really important. It's not just about health, it's about social care as well. But all of this will enable coordination between services. And a lot of our people say, you know, service A doesn't talk to service B, and there's a lot of disparity, and that will bring this together. I've got several other pages I can go through, but I'll just, I'll pause there actually.
Thank you, Michelle. I mean, your enthusiasm for the Integrated Care Partnership really shows. So I think your enthusiasm is a real assurance to us that to look forward to what's about to happen. Any questions? No? Laura? There was one, isn't there?
Not so much a question, just enthusiasm shared, I guess. The topic we've discussed many times today has been around workforce, and part of the requirement of that new integrated bill is around workforce and workforce support from the ICS. So I thought that was just worth flagging in the context of the conversation as well, because that obviously places a value on a piece we know to be missing from our local puzzle.
Just very briefly, we touched on, I think we're ahead here, aren't we? We talked already tonight about working together, and this is all about working together. We've started it, and it just gives us a framework to really accelerate that. And the really, really important thing that Michelle talked about for me is about the authority. So if we look at, the authority's got a different context for you guys, hasn't it? Sorry, apologies. John just looked at me quite rightly. Yeah, the authority within that framework. So what delegated authority can we have as an island place to really take the needs assessment for the population, create our plans, and then ensure that we deliver improvements for that population in those communities? So apologies for misuse of the word authority in that context, John, but that's the really important bit. And in really simple terms, it's how do we get the hands on the money and do the right things with it, to pick up on your earlier point.
Thank you very much for that. Now we'll move on to. Oh, sorry, John. Missed you out.
Sorry, John. Thank you. I did just want to, Chairman, apologies. I did want to add to that as well from Darren's perspective. I think because there's two things that the committee might want to be aware of. So firstly, because we have had an ICP for a period of time, we've got support from the integrated care system itself to be able to look closely at ourselves about how we might transform that quickly into a local delivery system or whatever system it is that comes afterwards, our place organisation. So I think that's really important. So we've got additional support coming in to help us make that change. And I think the other thing that's important to say is we can go as fast or as slow as we want. So it's at our pace. You know, come the establishment of the Hampshire and Isle of Wight ICS, it will have the responsibility for what goes on in terms of health services, but we'll be able to work with it to take, we can take down responsibilities more or less as we develop ourselves and get ourselves into a good place to do things. So I think there's something that's proportionate about how we manage things that links back to Simon's approach and responsibilities as a Director of Public Health to improve population health and wellbeing. There's a requirement on everyone to improve population health and wellbeing through this whole approach. But I think what we'll see is we'll even see the Hampshire and Isle of Wight ICS develop in that sort of way as well. So whilst the government has prescribed who needs to be on the Hampshire and Isle of Wight ICS, it has to be set up from the end of July or the beginning of July. So they may have to make some short-term decisions and evolve as they go along, and we will have to work with them to support that and evolve as things go along as well. So I think it's a really iterative process, but I think the good thing is that with Simon's involvement across Hampshire and Isle of Wight, we're well placed. With Darren's involvement and Nelson's involvement, we're very well placed across that, and we're having conversations about local authority involvement. So the four upper-tier local authorities are talking about local authority involvement at the Hampshire and Isle of Wight level, so that we get the structure right at that level that supports our local delivery system when it comes to be developed. So I think we're in a really strong place, but some more information that you might want to be aware of. Thank you.
Thanks. Right. Now we'll move on to the next item, which is the last item of business, CQC Inspection Reports. And this all looks good news. I mean, we're absolutely still delighted with where the hospital has got in such quick time. And you're going to give us reassurance that you're maintaining that position. I think it's lowest now, isn't it?
Thank you, Chairman. I started the pack that I put into the paper with a summary of our inspection posters, but it's occurred to me that those of you who have paper copies are probably printed in black and white, and it's not such a beautiful sea of green and blue that it is on the colour copies. So I presented those just as a reminder and to set the context for the rest of the discussion. By comparison with previous reports, which included several hundred requirements, must do's and should do's, we have only 3 must do's and 44 should do's. The must do's are summarised there. The should do's, very, very broad range of topics covered. Some of them are very, very specific, including recommending that we increase nurse-led services in a particular pathway. Others of them are extremely generic, such as the Trust should think about how it prioritises its IT spending. So a very, very broad range of requirements and a very broad range of ways in which we need to implement them and monitor them to make sure that they are working. We have now assessed all of the requirements and allocated them either to a divisional action plan or to our trust-wide one. Our trust-wide plan is updated and reported to our Quality and Performance Committee, which is a committee of the board very senior body within the council, but has representation on it from the CCG, from Health Watch, Chris attends our meetings, and from our own patient council, which helps to hold us to account on delivery of these must-dos. We also update the CQC on a fairly regular basis at our engagement meetings with them. These requirements were issued without a deadline, without any specific arrangements for monitoring them, so we report them periodically to the CQC. We did ask at our last meeting when it was likely that they would be back to inspect our performance, but regrettably the CQC's inspection regime at the moment is such that they are inspecting on a risk basis only, and as at the moment we do not represent a risk as far as the CQC is concerned, they're not planning to come back to see us purely to address our outstanding or remaining ratings issues, which is a particular disappointment to our ambulance and mental health colleagues who really would like to see improvements. With regard to the 3 must-dos, I've set out on the subsequent pages where we are. We must hold our hands up and say that with regard to weights for psychological services, regrettably those haven't come down significantly, partly because the number of people who need the service has increased significantly. A lot of that demand arose during lockdown. Services were unable to be delivered. A lot of it has arisen because of lockdown and the associated problems. However, we have managed to arrange our services so that people who are waiting wait more safely. They have other input during their wait, and we carry out regular risk assessment to ensure that those who represent us in more significant risk are escalated and prioritised. In the context of the conversations we've had earlier on, it's very pleasing to be able to report that we have managed to recruit some psychologists and assistant psychologists, so we're making progress there. I'm very pleased to report that work on our new health-based place of safety began today, and we are moving our facility for the time being into another part of the hospital site. That I think is expected to still to be in place by the end of May, but we're very pleased that work has begun. The risk assessment procedures, we've got the new programme in place, we've got the new tool, we have spread that learning amongst a wider range of areas, not just the ward on which it was identified. We've carried out our baseline assessment, and I'm confident that we will be reporting to the Quality and Performance Committee in due course that we have delivered the improvements that were expected. With regard to the should-dos, as I said, very broad range of subject matter covered, so I didn't present a huge amount of detail to you because I didn't think it would necessarily be helpful to you, but I can confirm that we have made some progress in all areas and we have made considerable progress in some areas. So it is a bit of a mixture, but the CQC is happy with us at the moment. We will be very happy to report to you again whenever you wish, Chairman. Thank you.
Great, thank you very much. So, any questions? No, yeah, we'll make a point by all means.
Just to have a, when you look at everything, it's, good. When we probably looked at it a few years back and it was inadequate, there's no inadequates there. And I think we should really praise that because, we've moved out of that. And the other one was outstanding in caring. Isn't that fantastic that actually the caring side, which to me is the most important, is outstanding. A big thank you to our island residents that care for our other island residents, because in fact a lot of the CQ different reports, we score outstanding on caring, and we need to really celebrate that we are a very caring community with that. And that goes, I'm saying, I've looked recently, caring scores the highest out of all the things. So let's support that we're a kind, caring community. Fantastic.
Michael, thank you very much for making that point. So now we move to our care homes, and I think we've got to say, Laura, I mean, you must be so proud of the results that we've had, and it's not just the 3 care homes listed now, it's the 4th one as well. So, really, really well done.
Thank you, Chairman. I am absolutely proud of that team. right across our internal services and everything that they've achieved. I'm delighted to be able to inform the committee that the Isle of Wight Council's care provision now in every single service is rated good, with the teams striving to secure their outstanding ratings at their next inspections. The inspection report before you for the Adelaide was a full inspection and saw their rating move from requires improvement to being good. So that was the last one of our set needed to bring us to that position. And the reports for Westminster House, for Saxonbury, for Pleendine and the Gouldings, which will follow in due course, were targeted infection prevention control inspections to make sure that everything needed to be as it was in those homes. The CQC enter, they look at infection control, they also look at everything else that they see. They speak to the people who are there, and I think that that's testament to the work that those teams are doing. I'm really proud of each and every one of them, and it's great that this committee recognises their efforts.
In the circumstances, the most trying of circumstances, very well done. Before the work plan, everybody's got a copy of the work plan, and I think we keep that up to date if there's anything that we need to add to it, and also from partners, if ever you would like us to add something to the work plan, then just please say. Now, before she missed it at the beginning, and before she goes, I do believe that this is Alison Smith's last performance at Scrutiny meeting, and it would be very remiss not to say, Alison, we've really appreciated the efforts that you've put in, your magnanimity at these meetings and your professionalism, the constructive way you've dealt with concerns that not always been easy to receive or handle. I think has really been appreciated, and we wish you all the best in your future appointments.
I just wanted to say thank you. This whole place and you as people have left a really big mark on my heart, and I'm not moving. I'm staying on the island, so I will be watching, maybe from a different distance than I am currently. But just thank you for the welcome and for working with me in the way that you have. It's been an absolute pleasure. So thank you.
Is this John's last one?
John, well, we did this at full council, John, but it's your last one as well, and I think we wrote that one to death, John, didn't we, at the time? Members' questions, we've had no questions, so thank you ever so much for everybody's contribution, and I think it's been quite a smooth meeting for a change. Oh, right, sorry, Charlie. Sherry, did you want to come in, or have I missed you off for some reason?
No, you haven't missed me. I just wanted to mention, and I told Charlotte, who is the service manager for Swan, that I'd mentioned this today. And I know that it's in the update, but obviously the advocacy people will no longer be providing the health complaints advocacy service from the 1st of April. The contract has gone to Southwest Advocacy Network, or Swan, who are providing all the other advocacy services on the island, the statutory ones. I will be moving over with them as well, being tupied over. So I have already spoken to Charlotte about our continued presence at this meeting, because I know when we discussed it before, we felt it was a good idea for us to be here. So whether it will be myself or whether it will be Charlotte or another member of the team, there will still continue to be somebody here. And I think it would be beneficial if it was Charlotte or someone else as well as me, because obviously they provide a lot of advocacy around social care, which of course is also discussed in this meeting. So we are currently getting consent from clients to transfer over, and we're hoping to make the process as smooth as possible for them all.
Thank you, Charlie, much appreciated.
You're welcome.
Right, and on that bombshell, as they say, meeting closed.